Afternoon, everyone. Welcome to our webinar for patient education on the remedē sleep system for treating central sleep apnea. We are joined today by Dr. Robin Germany, who is our Chief Medical Officer with Zoll Respicardia. Myself, I'm Pam Evans. I'm a nurse and the patient liaison here at Respicardia, and I will be helping both Dr. Germany and our special guest, Mike Dingledine, our patient ambassador, with today's webinar. To introduce Dr. Germany, she's a past clinical assistant professor at the University of Oklahoma and the Chief Medical Officer of Respicardia. She's been with Respicardia for the past 14 years and is dual trained in heart failure and electrophysiology. Prior to joining Respicardia, she was the director of the heart failure treatment and the medical director of the Heart, Lung, and Vascular Clinic at the University of Oklahoma. We also have, as I mentioned, Mike Dingledine, who is one of our patient ambassadors. Mike was implanted with the remedē system in January of 2021 and runs our patient support group on Facebook. Mike will be sharing his experiences with the remedē system and central sleep apnea today. This discussion will be followed by a live Q&A where both Dr. Germany, Mike, and myself will answer your questions as best possible. And if you have any question during the presentation, please go to the bottom or the top of your screen and you will see a Q&A box. You can type your questions in. We will also be available to answer questions after the webinar, and I will present you with contact information for the patient education team's email and phone contact. So with that, again, we thank you for joining us, and I will turn this over to Dr. Germany.
Thank you so much, Pam, and welcome everyone to the webinar this evening. We will cover quite a bit of material, so feel free to, as Pam mentioned, put your questions into the Q&A, and we'll do our best to get through as many of those as possible. So let's talk just a little bit today about sleep apnea, kind of ground everybody a bit in the sleep disorder. So this is classically what people think of when they think of sleep apnea. Somebody with their mouth wide open, maybe snoring. This is kind of that classic picture. But sleep apnea, when you define it, is any time there's a shallow or absent breathing for periods of time during the night. That absence of airflow is what characterizes sleep apnea. And it can happen for a couple of different reasons, but regardless of the reasons, the symptoms are very similar. There's a lack of stamina, feeling fatigued. Patients often feel sleepy or drowsy during the day. They may experience a brain fog where they just don't feel like they're thinking clearly. And interestingly enough, they actually can be anxious, especially at night when you go to bed and have trouble sleeping restfully. So these are typical signs and symptoms of sleep apnea. Now, as you can tell from this, oftentimes those may look like other things that you have going on. So sometimes those symptoms either can get missed or they're under-recognized how much they're contributing to what's going on. For example, if you have heart problems or you're not sleeping well because you have restless leg syndrome, all these things can look similar to sleep apnea. Now, if you do have sleep apnea, there's two different kinds, and it's really important as we talk about treatments here in just a little bit to understand which kind of sleep apnea you have. Now, the one on the right side is the most common. Obstructive sleep apnea occurs when there's a narrowing or blockage of the airway. Either it can be all the way up in the nasal passages or the nose, all the way down into close to the lungs. Somewhere in there, there's a blockage. Oftentimes when patients go to sleep, Your muscles relax even in your airway when you go to sleep, and that can close off that airway. So patients that have this closure have the disorder called obstructive sleep apnea, and they'll need a treatment that will help keep that airway open at night. Central sleep apnea, which most of you have heard of by the time you've made it to this webinar, is a completely different disorder. This is a disorder when your brain fails to send the signal to your body to breathe. So instead of trying to breathe, patients that have a blockage, they're trying to breathe. There's just a blockage. Central sleep apnea patients just stop breathing. So it's very quiet. Usually they don't snore, or they don't snore a lot, but there may be sounds made at night. Oftentimes people will describe gasping, because once you stop breathing, you're going to breathe really fast. And oftentimes that gets heard by other people that are around you when you're sleeping. So let's take a look at how this works. So the brain sends signals to the breathing muscles via a number of nerves, but the primary one is called the phrenic nerve. And it runs all the way up from the brainstem down to the largest muscle, breathing muscle that we have, which is called the diaphragm. And if you take a great big breath, that thing that you feel around the bottom of your rib cage is a giant muscle called the diaphragm. And when it contracts, it pulls air into the lungs. You can see them here expanding. And that's a normal way the breath goes. There's some accessory muscles in the rib cage, but the primary driver of that breath is this diaphragm contracting and pulling air into your lungs. So what happens if it doesn't do that? What happens if you stop breathing at night? Well, it actually sets up this kind of cascade of detrimental effects to your body. So when somebody stops breathing, we call that an apnea. When there's just very shallow breathing, at least 50% decrease, that's called a hypopnea. So small apnea, right? Not complete. There's still some breath, but it's not enough to be a normal breath. So each time that happens, you can imagine if you hold your breath, what's that going to do? Well, your oxygen level is going to drop. And with each one of these episodes, oxygen falls and you arouse from sleep. So you don't wake up. It's not going to be enough that you say, oh, I woke up from sleep. But it arouses you to where you can't get that really deep sleep that you want to have. Now, the problem then with lack of good sleep and low oxygen level is it affects not just your sleep, but it affects the rest of your body. You can imagine if you're not getting enough oxygen in, it can cause tissue damage. We call tissue damage due to low oxygen ischemia. Okay, so there's damage going on in the farthest reaches. It can go over throughout the body when this oxygen level drops. And that change can also set off inflammation. You know, we know more and more now that inflammation in the body can be hazardous. So this cascade of breathing sets up low oxygen, tissue damage, inflammation, and something we call increased sympathetic drive, which is an elevation of adrenaline, essentially, this fight or flight response. And with that, you can get spikes in your heart rate. You can get irregular heartbeats that come on. You can get constriction, cold hands and feet from constriction of the blood vessels. And over time, that can cause more detrimental or problems to your body. And it even gets worse if you have other illnesses. So here we have heart failure, which is the most common illness to occur alongside central sleep apnea, but it also occurs with other heart disease, atrial fibrillation, strokes, kidney disease. But in heart failure in particular, heart failure can actually be the trigger. It can be the initial cause of the central sleep apnea because it also is associated with high sympathetic drive, with high adrenaline level. And when that adrenaline level gets really high, that's part of what can trigger central sleep apnea. But once it gets triggered, it kind of goes off and runs on its own if it's not treated. So heart failure can make it worse But then heart failure is a big term for it means your heart is weak or it can't relax. And low oxygen levels can have a lot of stress on the heart. So central sleep apnea can actually worsen heart disease, and heart disease can worsen central sleep apnea. So if you have both, it's really important that your care team is taking care of both sides of this. But importantly, we now know that if you have central sleep apnea, even if you don't have heart disease today, that it can be a precursor for developing heart disease in the future. So let's take a step back, and you've heard this, hopefully you've heard some of that before. I'm happy to answer more questions about, the detrimental effects of central sleep apnea. But how do you know if you have it and how bad it is? Well, basically what we do is we add up all the times at night that you stop breathing or have shallow breathing, these apnea and hypopneas. This is an example right here of one sleep study. Every sleep lab reports it just a little bit different, but there's a couple of numbers that you should know. Okay, so if you can get a copy of your own sleep report, you want to look at the apneas and hypopneas, and they will then divide those by the amount of time that you are sleeping. And that's called the apnea hypopnea index, or AHI. And that's the most common thing that you're going to see on that sleep report. That's going to tell you how many times you stop or have shallow breathing per hour at night. And everybody has a few. So up to 5 per hour is considered really pretty normal. 5 to 15 is mild. There's some debate on whether patients have to be treated if it's below 15. 15 to 30 is moderate, and almost all sleep physicians will want to treat your sleep apnea if it's above 15. Above 30 is considered severe sleep apnea, either obstructive or central. And those are ones where those are patients that we really want to make sure we're looking at how to treat those patients best. Now, the second question then is, do I have obstructive or do I have central sleep apnea? And that is also pretty simple, except it may be difficult sometimes to find on your sleep study. So if you look here for this patient has 137 centrals and 12 obstructives. And it's just simple math. Which is bigger? This patient has not only more centrals, but a whole lot more centrals. So this is a predominantly central sleep apnea patient. And this becomes important as we look at the treatment. The treatment we're going to talk about today is going to treat the central apneas, okay? So the more central apneas there are, the more this treatment is going to work, because remember, these are these are disorders that are really different. One's a blockage, one's due to this brain misfiring of the nerves. So let's talk about the treatment now that you all are here to hear about today. It's called the remedē system. A couple of safety and important facts as we go forward. So it's indicated to treat patients with moderate to severe central sleep apnea only in adults. Remember, moderate is at least 15 events per hour. It is not MRI compatible right now. There's also a very special therapy that's used for some muscle issues called diathermy. It's rarely used, but that's something that you can't have with this therapy either. If you have another device, and we live in the bionic age, so if you have a pacemaker, a defibrillator, a neurostimulator, all of these can be typically used with the remedē system, but you want to make sure your doctor knows that before you go into the procedure room to have the device implanted. You can feel it. So we're going to talk to Mike here in just a little bit about what that feels like and how it takes time to get really used to the therapy. Usually this will just resolve with a little bit of time, but it is important to know that you might have some feeling. So this is what it looks like. This is the remedē system. It's implantable. Typically is placed about an inch below the clavicle on the right side underneath the skin. This is sometimes, because doctors really like to use a lot of slang, it's sometimes called the can or the battery or the device. but the device itself includes a battery and all of the electronics that make this device work. And then on the top is where the specialized wires will plug in that will help stimulate the phrenic nerve. And I'll show you where those go here in just a second. So this is what this is a little cartoon of what this device looks like. So this particular device has two wires. One goes into this very small vein called the pericardiophrenac vein, and it just floats into the vein. It's usually inserted through an IV-like device underneath the clavicle. It goes across the body and into this very small vein. It's very similar to a pacemaker wire. It's put in by physicians that put in pacemaker wires. You would be a little bit sleepy when you go in. The procedure itself doesn't hurt. And then it's specially designed to stay right there. It sits right next to the nerve. And it's going to then stimulate that nerve to fire so that you don't, so that breathing is stabilized. You don't have those pauses in breathing. Now, this particular device also has something called a sensing lead. Typically now we're moving away from that, and it's only a single wire. Some physicians, or in some cases, you may still need a sensing lead, and if so, that's placed towards, again, in a vein, similar to a pacemaker. So this is what it would look like from a cartoon standpoint. That stimulation is going to come down, stimulate the phrenic nerve. The diaphragm contracts, and you take a big deep breath. It shouldn't sting, it shouldn't hurt, but you'll feel your diaphragm contract, and we'll hear from Mike what that feels like. Now, what can you expect if you have this therapy placed? Well, it improves your breathing at night. So again, we measure all this with an apnea-hypopnea index. Here you can see that on average, patients started out in the severe category, well above 30, comes way down to this mild range, and the orange here are the central apneas. You can see that all the way out through 5 years, the central apneas are resolved. And it's not just the central apneas that are vastly improved, but the apnea-hypopnea index, oxygen levels improve all the way out through 5 years. So what does that mean to you? So these are a bunch of numbers that we talk about, but what could you expect if you had this device placed? Well, it's improving sleep. So as you would expect, it's going to improve sleepiness. So there's clinically meaningful improvements in how sleepy patients are. But not only just sleepiness, also how their overall health improves. So something called the Patient Global Assessment, how patients rate their overall health, improved in 79% of patients, and 95% of patients said they would have the device implanted again. Now, it is an implantable device. So with every type of implantable device, there are some risks. This is really similar to a pacemaker. 97% of patients had a successful implantation. 91% of patients were free from any serious adverse events. All of those, any kind of adverse event that happened, resolved by the end of the study. So no permanent, nothing like a death or anything from this therapy has been reported. So if you're interested in having this device placed, what does that look like? Well, number one, you need a sleep study. So if you haven't had one, or it's been 10 years since you had a sleep study, you might need to get a sleep study. And a sleep physician is typically the one that does that. Then you would go to see a cardiologist, usually one that's partnered with your sleep physician. And the implant is done as an outpatient procedure. So we've seen now most patients go in the morning, go home in the afternoon. Some physicians may, especially if it's a late case, keep patients overnight and go home the next day. But the therapy is not actually turned on that day. So the device is turned into monitor mode. It's going to measure your sleeping habits for that first month while the device heals in. When you come back into the office, and in the office, the device is actually activated, turned on. And the information that the device has gathered for that first month is used to help program and personalize that device just for you. And then over the next few months, you'll have a number of visits to really program that device just for you. Think of it as your own very personal device that is programmed to know so that when you go to sleep, it will work just for you. Your settings may be very different than someone else's. I'm going to answer a few sort of common questions, ones that always come up. Maybe some of these are already in the chat or the Q&A, but I'm going to put a plug in as I answer these questions to please put your questions into the Q&A so that we can answer them, because if you have that question, so does someone else. So one of the things I didn't really mention earlier is when I say it's programmed just for you, the remedē system actually activates on its own at night. So there's nothing you have to do. There's no button to push. There's nothing, you don't have to dial into your cell phone. When you go to bed, it's going to turn on. So how does it know when to do that? Well, first, it's set up for your time schedule. So it's going to come on at a time that you and your physician work to. Say you typically go to bed at 10 o'clock, it's going to come on at 10 or 10:30. Okay, give you a few minutes to get to sleep. It'll start out slow and come up to being very effective. But not only does it have to be the right time, you may go out to dinner late one night. We just got through the holidays. You also have to be in the right position. So the device will recognize whether or not you're lying down and in your sleeping position. It will only come on when you're in that position and when you're not moving. So if you're rolling around in bed, trying to get comfortable, it's going to wait until you're in a quiet sleeping position before it comes on. And so say it comes on, you're not quite ready to go to sleep yet. Maybe your mind is racing that evening. All you have to do if it comes on and you're not quite ready is sit up. And when you sit up for at least 30 seconds, that therapy is going to suspend, and it'll then give you 15 minutes, maybe longer, to get to sleep, and then restart. So we want you to get, as much therapy as possible, but it's also designed to make you really comfortable with the therapy. So what are the next steps if you're considering proceeding with this, with the remedē system? Well, talk to your doctor, okay? This is not a therapy for everyone. So make sure that you've talked to your physician about your medical condition. If you would like to speak to a physician that specifically knows and is taking care of patients with the remedē system, you can use the Find a Doctor tool. You can also take and fill out some information on the website. That's how many of you got here. But if you have not, this website has been updated, and I'll ask Pam to put it into the chat so that you can click on that and get information back to Pam. So with that, I'm going to pause because I think the most important part of this webinar is hearing from our patients. And so Mike, I'm going to stop sharing here and first express how appreciative I am of you being here this afternoon and for sharing your story with patients. So I will pass it over to you.
All right. Well, thank you. I really appreciate the opportunity, and I appreciate the invitation to join you. Hello, everyone. I'm going to go back a little bit in time here because my story begins back in early 2017. I had reached a point in my life where I didn't know what was going on. I felt terrible. I felt all of the symptoms that Dr. Germany had alluded to at the beginning at some of those. But what I didn't know was why, what was going on. What I did know was that, simply put, I was tired all the time. And I had been concealing this from my wife and others, not saying anything about it, but just progressively it was building. And I just had no desire to do much of anything, no will to do anything. When I tried to do things, I would just get tired. And I could go to sleep at the drop of a hat, except I couldn't stay asleep. I was waking up all hours of the night. And by that, I mean, I'd go to bed at 9 o'clock at night, fall asleep, wake up thinking, wonder what time it is. Oh, it's 9:30. Oh, time to go back to sleep, wake up again. And this was just progressively night after night after night. So anyways, I thought, well, it's time to talk. So I sat down with my wife and we discussed this, and I told her how I was feeling. And she suggested that I make an appointment with our family doctor, go see them and talk to them, tell them the story, tell them what was going on and see what they had to say. Well, I was a little bit apprehensive about doing that because I was a little bit scared. I didn't know what was causing this, but I did that. I made the appointment and I went and I met with a nurse practitioner. And I told her how I was doing and how I was feeling and the energy levels and my sleeping habits and so forth. Well, she suggested two things. One, she wanted to do some routine blood work just to rule out some other possibilities and so forth. And the second thing she wanted to do was a sleep study. Okay, well, I guess that makes sense. I'm not sleeping, so maybe that's going to tell me why I'm not sleeping. So I did that. I did a sleep study, a lab sleep study. And a couple of weeks after the sleep study, I had an appointment with a local sleep physician. And that's when he told me that I was stopping breathing on an average of 52 times an hour. So that put me in the upper severe category, if you want to say that. But that's where I was. And he explained a little bit to me about the different levels and so forth. And okay, so what are we going to do about this? So his suggestion was that we get a CPAP machine and try with that. So I did that. I got the CPAP machine and he set that up for the different levels. And we started out with a nose pillow type of mask. Many of you may use that or have tried that. So anyways, I tried that, and over a period of time, it just not working. I was still waking up all hours of the night. It was not comfortable for me to wear. And so at my next appointment with my sleep physician, he looked at the numbers and said, well, this isn't getting any better, so we'll make some adjustments to your settings. And I suggested, well, maybe we go to another type of mask. Okay, we tried that. Still to no avail. It just wasn't working, wasn't helping. And I'm going to fast forward a little bit here because I struggled with that for probably mid-2019. It was in the summer of 2019, and I was still having this difficulty, still trying that CPAP machine because I was told that was what was going to help me. I needed to learn how to sleep with that, and that was going to be my saving grace, so to speak. But anyways, I was listening to the radio. It was in the summer of 2019, and I heard this advertisement about this device that you push this button and turn this on, and it was for sleep apnea. And many of you may have heard of this. It was called Inspire. So now I've got this new word in my vocabulary, Inspire. So I'm a big Google fan. So I go to Google and I start looking up information on this, and I go to their website and I find out everything I need because I was going to have an appointment with my sleep physician in the coming weeks. So I went to their Find a Doctor and I found one. I'm located in Ohio. I found one at Ohio State that dealt with sleep apnea and Inspire. And I took all that information with me to my sleep physician appointment. And he again told me that my numbers weren't improving. We needed to make some more adjustments and maybe we could try another mask. And at that point, I said, let me talk a minute. Okay, here's what I heard. Here's what I found. And I think maybe I wanted your opinion on this. So he listened to what I had to say and thought, I'd be a good candidate for Inspire. Okay, so he said, well, if you want, I'll tell my staff, direct them to send in your records to the physician, the doctor that you found at Ohio State, and we'll wait till you hear from them. They'll set up an appointment and so forth. I said, okay. So this was in October of 2019 when I went to see a doctor at Ohio State by the name of Dr. Chu. I went in, my wife and I went in. He came in and introduced himself to us, and he immediately pulled over a whiteboard. And on that whiteboard, he wrote OMC. I'm sorry, I don't know what OMC stands for, but he proceeded to tell me. So he said, okay, he said, for obstructive, the O, he said, you have 0. You have 0 obstructive. For the mixed, the M, you have 4. And for the C, for central, you have 143. He said, you are all central, no obstructive. And I'm looking at him like this dumbfounded look. And he says, you act like you've never heard this before. And I said, well, I haven't. I thought sleep apnea was sleep apnea. Oh, no, he said, there's central and there's obstructive, and you're all central. He said, unfortunately, the Inspire system is only for obstructive sleep apnea, so I can't help you. He said, but the good news is I have a colleague here at Ohio State by the name of Dr. Agostini that deals with central sleep apnea patients. And if you would like, I'll direct my staff to send your medical records to Dr. Agostini's office, and you can wait to hear from him. So we did that. I thought, okay, now I have another word in my vocabulary, central sleep apnea, because up to this time, I just thought I had sleep apnea. So I went home, and obviously I started Googling central sleep apnea. And quite frankly, what I read about it wasn't very pleasant. It didn't look to me like it was going to go away anywhere in the near future without some type of a treatment. So anyways, I got a phone call to set up for an appointment. And I went in and met with a colleague of Dr. Agostini's, a nurse practitioner by the name of Julie Meese. I met with her in, it was early November of 2019. And she explained to me central sleep apnea and the device that they had. It was called the remedē system. And this is what they use to treat patients with central sleep apnea and the benefits of this and so forth. So I was asking Julie, I said, okay. So I asked her a lot of questions, and she said, so what would you like to do? And I said, well, based on the fact that the information that I had found on Central, I don't think there's any turning back. I said, I need to progress. I need to go forward. So yes, I want to move forward with this, but what do we need to do? Well, she said, your sleep study was almost 3 years old now. She said, we'd suggest that you have another sleep study, a lab sleep study, and we can make sure that you meet the criteria for that, based on the results of that study. So I did another sleep study. This was late November of 2019, and I was waiting to hear back the results of that, which I did in early December of 2019. I was contacted by them, went in for another appointment. And that's when she told me now I was stopping breathing on an average of 57.6 times an hour. So in that 3-year span, it had progressively gotten worse. Okay, so that tells me it's not going to get better. It's going to keep getting worse. So, okay, so now what do we need to do? Well, she said, if you're still interested in proceeding, we'll take your insurance information, file on your behalf, and we'll get back with you when we hear something. So I did that. Gave that to him, and I got a call back. It was mid-December of 2019. Everything was moving pretty quickly. And she said I had been approved for the device, for the surgery, and that they had an opening on January 9th of 2020, if I'd be interested in taking that. Well, there's no turning back. Let's do this. I think now I'm on the right track. I found something that's finally going to help me. So I went in on January 9th of 2020, had the surgery, remarkable surgery to say the least. I was a little bit apprehensive because they talk about you're lightly sedated, you'll be awake during this procedure. I'm not real big on that, but I thought, okay, well, we're going to give it a try. But it was remarkable. Didn't feel a thing. Had a nurse stationed by my head. She talked to me throughout the procedure. When I needed to take a breath, hold a breath, inhale, exhale, whatever, she was there to tell me what to do. So I had the surgery. The implant was in. Went back to my room. Laid around for a while, had lunch. I had to wait a few hours to get in to get an x-ray before they would dismiss me to make sure that the leads had not moved. Everything looked good. And by 4 o'clock that afternoon, I was back in the car heading home. Okay. With the understanding that even though the device was there, it wasn't activated yet. Okay. I had to go back in 4 to 6 weeks, they said, and before activation, but they wanted to give the time for the leads to heal in. And they gave me some very simple I thought things that I could not do with that. One being I was not to raise my right arm above my shoulder for a period of 4 to 6 weeks or until my activation date. I was not able to lift anything greater than 10 pounds with my right arm, which I said, okay, 10 pounds, they equated that to a full gallon of milk. And the third thing that I couldn't do was push or pull anything using a greater force of 10 pounds with my right arm. So basically, don't do a lot with your right arm, use your left. And it was going fine. I couldn't go back until 6 weeks because of a scheduling conflict. But when I went back in at 6 weeks, it was explained to me that even though the device had not been turned on, that it was collecting data, how I slept, right side, left side, back, when I went to sleep, my sleeping patterns and all that information. So at my activation period, I was met by, again, Julie Meese, a representative, the area rep from Respicardia was there, and 2 technicians were present for the activation. And we discussed the data that they had downloaded off the device and set the device up for a right side, left side, back setting. Okay. And with that, I was told that it would increase in intensity. The signals would increase in intensity over the period of the next 6 weeks. Each week, it would jump up just small increments and see how that goes. It was always with the understanding that the sensation was to make the diaphragm inhale, exhale, and give you a fuller breath of air, which was essential to the process. So we did that. At 4 weeks, I developed a little bit of uncomfortable feeling on the right side. It was a little bit stronger than what it had been, and it wasn't anything too bad or anything. And I contacted Julie. She said, if you want, I'll bring you in and we'll make the adjustment. I said, I'm due to be there in 2 weeks. I'll just avoid that right side and we'll get by. So I went in at 6 weeks. They downloaded the data again. She adjusted the right side setting. Never had a problem since. So it was, it's set up to come on at a lower sensation to allow you to get to sleep. And then it ramps up, which is a term that they also use for a CPAP machine. They ramp it up over a period of time when you're asleep and increase the intensity to give you a fuller breath of air, which was, again, essential for the process. And I started feeling better. I was getting sleep right away. The first night I went home after activation, and I was a little bit apprehensive about what I was going to feel. And I called a patient ambassador at that time that was I was connected with, and I talked to Sean. I said, so what am I supposed to feel? What am I supposed to do? He said, what time is it supposed to turn on? I said, 11 p.m. He said, well, go to bed about 10:30. Try to go to sleep. See what happens. I said, well, that's short and sweet, and thank you, but it's me. But in retrospect, it was the best advice he could have given me, because that's what I did. I went to sleep around 10:30, fell asleep, and didn't wake up the whole night. Now, is that the norm? No, it's not the norm. I don't want to try to tell anybody that that's how it works. If you're lucky enough that works, that's great. But I'm at the age where from time to time I have to use the restroom through the night. So if my body wakes me up to do that, I get up to use the restroom. I'm also a diabetic. So if my blood sugar drops through the night, I have to get up to address that. But when I do wake up because of that, I simply sit up, give it a short period of time, the device turns off, get up, go do what I have to do, go back, get in bed, and the device is already programmed to be turned on because it's in that window. So that's the first criteria that's met. The second one is, okay, I'm in a restful position. Okay. The third one is I'm motionless for a set period of time, which is a programmable time. It's based on everybody is a little bit different. You might like 5 minutes, you might like 10 minutes, maybe longer, maybe less, and it can be programmed for you for that. So at about 3 months, I was feeling pretty good, feeling more restful. It was okay. Everything was good. And when I met with Julie at 3 months, she made some more adjustments, and I told her how I was feeling. At 6 months, the same thing happened. And so Julie said, okay, maybe it's time to do a sleep study. Let's see how this is. Let's see if it proves out to be that way. And so in September of 2020, I did a sleep study. And even though it had shown some remarkable improvement, it was still not where she thought it could be. So we made some further adjustments. And we kept that process up. And in August of 21, I did my last sleep study. It was my second one with the device and the last one that I've done since getting the device. And at that particular time, the results were that my AHI, which was 57.6, prior to getting the Remedē device, was now at 4.3. My central events were 0. So that's pretty good numbers. Okay, I was ecstatic with those. And we've made no further adjustment settings since that time. So we've not had to change any of the settings or anything. We did change an incline setting, but not a sensation setting. So it's been well. So it has been a remarkable journey for me, one that I'm very glad, thankful for, that I found Respicardia, because up until the time that I met with Julie Meese, I never heard of Respicardia. Okay, I never heard of the Remedē system. And so it opened my eyes. The implant has worked great. And I feel a lot more active, restful. It's been a good trip. So I really appreciate what Respicardia and that device has done for me, given me back a quality of life that I one time wondered if I'd ever see again. So I appreciate everybody listening to my story. Thank you.
Thanks so much, Mike. I always really appreciate when you share your story. I'm sure there's going to be lots of questions. So as Pam gets ready to look through the questions and ask them, I always like to ask you the first question, right? So, what are the biggest changes that you have noticed and that your family's noticed since you are now getting better sleep?
Okay, what I have noticed, okay, like I said, more energy, more will to do things, I'm more active, able to get out and, do some outdoor activities, chase my grandchildren around to their activities and things such as that. What others have noticed is possibly some of that as well, that I wasn't noticeable as much at some of these things possibly for a while. Where's Mike at? He's not, he's tired or whatever. But one of the most telling things that I had a discussion with my wife after I'd had the device and was sleeping better and getting a little bit more active and energized. She laid something on me that unbeknownst to me, but she thought that I was a lot nicer person now that I got the Remedē system, that I was able to get some sleep and such. And I'm really, I thought I was a nice person, but in retrospect,
I think you're a nice person, Mike.
Thanks, thank you. But in retrospect, she was right. I was tired. I was irritable. I had a short fuse. And looking back, I can accept the fact that I was, and I hope that others can accept that too. In fact, I've actually apologized to maybe a few people over time and explained to them what I had been going through so that they might, better understand what that is. But, missing a night's sleep is not a big deal. Try doing it night after night, day after day, week after week for a long, long, long time. And it wears on you. It really does. It wears on you. So, So she opened my eyes with that. So thanks for asking.
So we do have some questions that we want to get to. I'm going to kind of combine some of these or ask for a little expansion on them. So let's start out with, can the remedē device be used with other implantable devices? And is there a plan for the remedē device to be MRI compatible in the future?
Well, that's great. So as I said, starting out right now, it's not MRI compatible, but yes, hopefully in the future at some point it will be, but we don't know when that is. So really having a good discussion with your physician about what your risk to need an MRI is a great question to talk to your physician about. On the other hand, testing, we've always known that our patients are likely to have cardiac devices. So in the clinical trial, 44% of our patients had a pacemaker or defibrillator. We have lots of experience with those devices. It does require testing. So one important thing is if you have another device, that you make sure that your physician that's going to take care of your remedē system or implant the remedē system, that they know you have that other device so that they can be programmed appropriately. And if you ever get a device later, so you end up in the hospital, 15 years from now, you need a pacemaker, make sure that both of your doctors, your remedē doctor and your cardiologist that puts those devices in knows about each other. So these are, luckily in today's world, we can do a lot of great testing and programming, but sometimes if they don't look at the right x-ray, they may not see that other device there.
So another question that is rather common is, can the remedē device be used to treat mixed or complex sleep apnea?
So in general, it's only going to treat the central sleep apnea. So occasionally you can have a few events that are obstructive that are really due to the central sleep apnea. So say you had an apnea-hypopnea index of 50 and you had 4 or 5 obstructives, it might be able to do that. But if you're a 50-50, half obstructive, half central, then you're going to need to have a different treatment for that different disorder. So you might need low-dose CPAP or a dental appliance. There's a couple of other new therapies that are out that can be used for obstructive sleep apnea, including other neurostimulators. So you would need a treatment to treat that disorder, which, although diagnosed both on a sleep test, is fundamentally different than central sleep apnea.
Have there been any clinical trials using both types of neurostimulators, the remedē and Inspire, or are there plans for clinical trials for a new device that could handle caring for both issues that you're aware of?
That's a great question. So, there's always new research going on. So I'm certain that in the future that there will be attempts to treat patients with both disorders, but it's not on the market yet. And I don't think there's a line of sight to when that'll happen. So we do hope in the future. It'd be nice to have everything taken care of in one device, but we're not there yet.
Okay. Dr. Germany, can you also talk to any concerns with electrical interference when you have this type of device implanted? Like, going through the airport or a cell phone or a microwave oven. What are the concerns related to that?
That's a great question. So with a cardiac device, which is where a lot of these warnings come from, it can mess the device up when you're around that kind of electrical magnetic interference. So the worst case scenario is somebody has a pacemaker, they stop in the middle of the x-ray machine and it can prevent the pacemaker from working. This therapy is only going to work at night when you're laying down. So most of that type of interference is not going to bother the remedy system because you'd have to be using it while the therapy was active. So one case scenario would be if you directly put your phone at night on top of your device. And I will say that I occasionally sleep was reading my little Kindle on my phone. That can actually, there's a big magnet in your phone, and that can prevent the therapy coming on for that night. But the device is designed that it will come on again the next night. So you won't miss it for a long time. But yes, if you place a big magnet around that device, it can suspend therapy. So we want to have you stay away from that. If you go through inadvertently a metal detector, you may alarm the metal detector, but it's likely not gonna hurt anything. In a real rare instance, some settings can be reset. So if you ever feel something different suddenly, make sure you call your physician and ask them about it. But typically those types of things are not going to cause any problems. Sometimes we get questions about microwaves or there's some electrical stuff that happens on a plane. There are a couple of instances in heart devices where it has done stuff. We haven't yet seen it with the remedy system, but it's theoretically possible. So anytime you see a big change, make sure you let your doctor know.
Okay. Can you talk more about the battery life of the device and what's involved with a switch out of battery? I know Mike has gone through one, so maybe you want to tell us about your experience with the battery switch out, Mike. And then Dr. Germany can talk about a little more of the medical details there.
Okay, sure. I did have to have my battery or my device replaced in actually January of last year. The battery expired, and but it was explained to me that also the sensation that the pulses that you get, the therapy that you get, could reduce your battery life depending upon how strong your settings are. In my particular case, my settings are somewhat high, and so my battery wore out. But I went in, I was approved insurance-wise for a replacement. I went in, Dr. Augustini did the replacement, and from the time they had me prepped till the time that I actually got off the table, it was about 30 minutes. Okay, he opened it up, unplugged it, took the old device out, put the new device in, plugged it back in, sewed me back up, and there were two technicians from Respicardia there that activated the device right away again. So it was probably 30, 35 minutes, something like that. I was headed back to my room and had lunch, and within the hour, I was back on the road heading home. And the device was back to where it was previously that it had died. If I may, just to go back a little bit, Pam, you had asked a question about both devices, and we have in our Facebook group, we have a gentleman that has both Inspire and Remedy, and is working great for him. He went with Remedy first, and then he saw what his numbers were with the obstructive, and he thought, okay, so what's his alternative? And he's got both devices. And we have another member that is very close to getting both devices. So they do work well together. There's been no interference, no problems with that. So I just wanted to throw that in there.
Thanks, Mike. And you have a great discussion about how the batteries changed out. It's from a physician standpoint, it takes about 15-20 minutes. So it's a very short procedure. It's all the prep that goes in. So it still takes a little bit of time, but it's all like getting you there and getting you home. From a battery life standpoint, this is a little different than a heart device because it depends on how much you need it. So some patients need a lot more energy to be able to control the breathing, and some patients, their breathing is controlled with very little energy. And so, and Mike, I think you can even talk to this, right? Your battery is on a little bit of the shorter side, but on average, it's about 3.5 years. Some patients will be shorter than that, and some will be longer. And honestly, we just won't know until we get that therapy program just for you. The good news is there is a new generation of devices that is coming, and this is a normal for all implantable devices, that over time, from the first cardiac pacemakers, we continue to see batteries last longer with each generation that comes out. And so, you know, while it may be less than 3.5 years currently, hopefully in the future, we'll have batteries that will last even longer. That technology just always seems to be growing.
Dr. Germany, can you expand a little bit when a gen switch out is done?
Mm-hmm.
Are the leads replaced, or do those remain in?
So typically the leads, which are these stimulation wires, are left inside. If there's any hint that for some reason the wire is not in the best place, or there's some concern about it, it could be changed. So if they know they're going to change it, they may do that at the same time. But most of the time, and I would say like in the 95% plus, they're just going to take out the box, the can. They sometimes call it the battery, but it's that whole picture that I showed you. That device just unplugs, you plug a new one in.
This is a question I think both of you could probably field. Maybe we will start with Mike telling what were your restrictions after you had the implant? What were your activity restrictions? And then Dr. Germany, if you want to add or supplement on that, please do so.
Okay. As I stated before, I only had 3 restrictions when I left the hospital. And I'm hearing from more and more of the Facebook members, that they may have a sling as a precautionary. I was not told I had to wear a sling. And like I said, I was not allowed to raise my right arm above my shoulder for a period of 4 to 6 weeks, or until I was called back in for activation. Not allowed to lift anything greater than 10 pounds with my right arm, which was equated to a full gallon of milk. And if I was pushing on a door or pulling on a door, not to use anything greater than 10 pounds of pressure, which is kind of hard to gauge for me, but just use that left arm, or hey, somebody else will open the door for you or whatever. But I really, there are very few restrictions. I mean, I was able to do things, right away to help out around the house. Not that I'm a big dishwasher, but I was able to, you're able to do that. You're able to move anything lower. I mean, it wasn't that you couldn't move your arm or anything for a period of weeks. You could use it right away. There were just some restrictions, as a few things that you couldn't do. So hopefully that answers the question.
I think that's a great answer. I think we've learned, so there's an ever-growing list of things we don't expect patients after they've had a procedure to go home and do. So, we aren't going to want you to play golf the next day, because those wires can pull out for those first few weeks. We don't want you to go home and hoe the garden, bale hay. So these are real patient stories, because that lead for about 6 weeks has the potential, if you strain that arm, to pull back. And having said that, though, long term, the whole goal of this therapy is to get you back to living. So while for the short term, there are a few changes, there are a few restrictions, over the long term, we do want you playing golf, and we want you to go and live life. And if you like to play tennis, we want you to play tennis, because that is the whole goal of this, to really get you back to your best life.